Good afternoon, everybody. After lunch, I think everybody must be feeling sleepy. Let's go ahead with our topic. I thank Dr. Namrata for giving me opportunity to speak over here and the AIS midterm conference. Thank you. My topic is workup of a case of pediatric cataract. Evaluation of pediatric cataract requires a coordinated team effort involving ophthalmologists, pediatricians, anesthetists, orthopticians, counselors, and parents. Family history of any systemic disease, antenatal history of rash, febrile illness, drug intake, and X-ray exposure is must. You have to take the natal history and the history of child growth and development, feeding and digestive behavior. Physical examination by pediatrician, you have to, it can be associated with myriad of systemic conditions like chromosomal anomalies, craniofacial, mandibulofacial, skeletal syndromes, metabolic disorders, congenital infection, dermatologic, CNS, musculoskeletal, and renal disease. Now, visual acuity estimation as per age is a very essential thing. First, the most important thing is the red reflex or the illumination test, which is to be done in the pediatric case. It should be done in an undilated pupil to assess the, estimate the visual significance of the opacity. Any central opacity or the surrounding cortical distortion of more than 3 millimeter in diameter is visually significant. Now, in the picture you are seeing the top, can I have a pointer? In the picture you can see there is a anterior capsular opacification. Now, usually the anterior capsular opacities are not visually significant, but only if it is acquiring more than 3 millimeter in diameter, occluding entire pupil like this, which is the anterior pyramidal cataract, it needs to be operated. Most of the time it does not require any surgery. Now, this is a case of posterior sutural cataract, which is a Nance-Horan syndrome. Usually females carriers have this kind of cataract, but usually if the opacity is not having a very good, when you are doing retinoscopy, if lot of area you are getting red reflex and it is not hampering the visual axis, then you need not go for the surgery. This is the posterior lenticular opacity, requires surgery. Now, here you see this is an anterior lenticonus. When you see the lens morphology, this is the anterior lenticonus, and anterior lenticonus is associated with Alport syndrome, and this you can see a posterior lenticonus. Posterior lenticonus it progresses with time, and at times what happens, gradually the patient might get an acquired cataract, but usually it also does not require surgery unless and until sometime it develops tear, and in that case total lenticular opacity appears and you require to get it operated. These are the various morphologies, and you can have different type of cataract like Christmas tree, rosettes, purulent cataract, and at times you can get green flecks and Wilson's disease. Traumatic cataract needs to be operated, you have to evaluate everything. Now, lens position, it can be a superiotemporal or inferior nasal subluxation, and it can be a spirophakia in Weil-Marchesani syndrome. Then you have to look for the lens position also. While evaluating the posterior segment, it's important to do a B scan to rule out any persistent hyperplastic primary vitreous, any retinal tumors, or any retinal detachment. Any associated strabismus, usually unilateral cataracts are associated with strabismus, which is suggestive that already the time of surgery is gone, but still you have to go ahead with the surgery. Any bilateral cataract will be associated with nystagmus. That is also suggestive that the time is gone, but you have to go ahead with the surgery. Now, systemic evaluation investigation, especially done in those children where infective etiology such as rubella or metabolic disorders such as galactosemia or syndromes are suspected. A tailor-made investigation is offered in torch, hypoparathyroidism, hypoglycemia, galactosemia, syphilis, Alport's, homocystinuria, etc. Investigation to be done are IgG, IgM titers, blood sugars for diabetes, galactose 1-phosphate levels for galactosemia, VDRL, and urine protein for homocysteine, and urine amino acid and copper levels, and serum calcium and phosphorus for hypoparathyroidism. Now, evaluation under general anesthesia, it's a standardized protocol for every patient. A full team of ophthalmologists, anesthetists, pediatricians, technicians, and supporting staff need to be present during evaluation. Laryngeal anesthesia is preferred. In selected older children, you can go under ketamine also. IOP measurement is done following induction of anesthesia. The first procedure is applanation tonometry performed using Perkins handheld tonometer. Keratometry is performed by an experienced examiner and an average of 3 or more reading are to be considered. Axial length measurement is performed using immersion ultrasound and an average of 3 or more good readings is considered. Corneal diameter, both horizontal and vertical corneal diameters are measured using operating microscope using a caliper which measures in steps of 0.5 millimeter. Slit lamp examination to look for the corneal clarity, the anterior chamber depth, anterior and posterior synechia, iris configuration, lens morphology and position. One of the most important thing is you should document everything by video recording or clinical photographs. Gonioscopy is performed using a slit lamp attachment of a microscope. Angle structures visible, the degree of pigmentation, any angle anomalies are noted. Detection of any angle anomaly has a prognostic significance in development of glaucoma. Now, in the end, the dilated retinoscopy is performed by a trained, experienced optometrist. Thus, a detailed evaluation helps us to better plan the surgical strategies and give the prognosis to the parents. Thank you.
Yeah, very beautifully covered, Kavita. Very nicely covered about what are the things you should do